Welcome to part 2 in our two-part series on COVID-19. Part 1 discussed the epidemiology, and in part 2 we're going to talk about the pathophysiology, signs, and symptoms. So COVID-19 is transmitted by respiratory droplets, and these droplets are usually emitted from an infected person by coughing or sneezing. And so when those droplets are breathed into someone, they tend to hang out and get caught by the mucous membranes in the nose, mouth, or more commonly in the back of the throat. And those are the first sets of tissue that get infected by COVID-19. So in this particular drawing, these 5 cells here represent the lining or the mucous membranes in these areas of the nose, the mouth, and the back of the throat. Okay. And on each one of our cells, we have receptor sites. And COVID-19 is drawn to the ACE2 receptor sites. And these are the angiotensin converting enzyme sites that are used by the cell to communicate with the rest of the body. So these are fairly common receptor sites, and a number of the cells of the body have these. And any cell that has an ACE2 receptor, COVID-19 can bind with. Now, each cell has a series of organs, or organelles as they're called, to allow this cell to do whatever it needs to do, reproduce itself, repair itself, and whatever function that particular cell has, there are organs or organelles in order to be able to do that. One of the types of organelles inside a cell is the ribosome, and ribosomes are generally responsible for producing materials that the cell needs. And the cell also has numerous types of enzymes. So in this case, the blue line inside these cells is the enzyme that helps copy the virus's RNA. So cells need to reproduce, so they have to be able to copy their own DNA. Well, when somebody is infected by a virus, the virus essentially hijacks the cell's organelles and uses them to replicate copies of itself. And that, in fact, is exactly what's going on with COVID-19. So remember, somebody breathes in these respiratory droplets that contain the active virus, and they get caught up in the mucous membranes of the mouth, the nose, and especially the back of the throat. You know, think about the air coming in through your mouth and nose, bounces off the back of the throat at that T intersection before getting sucked down into your lungs. So all the particles that are in there are going to bounce off the back of the throat, and all of these cells produce mucus designed to actually trap particles to protect the lower airway. And so it's actually doing a pretty good job of that, at least in this instance. So here's a COVID-19 virus particle, and it's just been inhaled into this particular person, and it's stuck now in their mouth or their nose, or more likely on the back of their throat. And there it binds with the ACE2 receptor. When it binds with the ACE2 receptor, it injects its RNA into the cell's cytoplasm, the fluid inside the cell, and then that gets absorbed by a ribosome. Once it gets absorbed by the ribosome is then going to read that RNA of the virus and say, okay, I'm going to duplicate this. So the first thing, or one of the things that it does, is it duplicates and makes the proteins that are necessary for assembling the different component parts of a cell. So all these little polyproteins are generated, and then it takes those polyproteins and makes the spike particles, the capsule for the virus, the enzymes, everything that is going to be needed to assemble the entire virus, with the exception of one thing, and that's the actual viral RNA. Well, other ribosomes, or the ribosome here, is then going to copy that RNA using the enzymes that it has, and now we have everything we need inside this cell to reproduce the COVID-19 virus. And in fact, that's exactly what happens. You get all the component parts, and they get built together to produce a virus. Now this virus is going to, these organs are going to continue to make virus particles until there's so many virus particles inside the cell, it basically overwhelms the cell's ability to create even more and bursts through the cell membrane to infect other cells that are next to it. Let's see what that looks like. So here it's just all of a sudden they're making more and more and more and more of these viral particles until it actually breaks out of the cell, destroying the cell, its organelles, and then the different virus particles then go to other empty ACE2 receptors, inject their RNA, and the process starts over again. And in this manner is how the virus actually moves down a person's throat into their lungs, if it's going to do that. So the early signs and symptoms, and this happens in maybe 30-40% of people, is a loss of taste or smell. This sort of makes sense if you think that remember that there are ACE2 receptors on your tongue and in your nasal passages. And if the virus, instead of getting stuck in the back of the throat, actually gets stuck on the person's tongue and infects cells on the tongue, they're going to lose their sense of taste as that virus replicates itself and destroys those cells. Same is true in the nasal passages. If the lining of the nasal passages are getting infected, there's a good chance that they're going to lose their sense of smell. Sore throat and a dry cough are super common in this virus, and that's because most of the stuff gets caught in the back of the throat. And as the infection in the back of the throat starts to grow, it hurts, hence a sore throat. It gets red, it gets inflamed, it swells a little bit, and it's irritating, and you'll see a dry cough as a result of that. Well, if that's what's going on, you may well have COVID-19, and we need to do a swab to see if that in fact is what's going on. Now, it's pretty normal when people get an infection of any kind that they start to develop a fever. And this is essentially a pretty low-grade fever, 102, maybe a little bit greater, maybe a little bit less, but somewhere around in there to say, hey, the body defenses are being engaged, we're getting some inflammation. If you look in the back of their throat or their tongue, or look in their nasal passages, you'd see they're a little bit red, there's a little bit of swelling going on. This is all a result of the battle that has started between the body defenses and the virus itself. Muscle soreness is pretty common because at this point, all the focus is starting to turn to fighting off this virus, and there's a lot of debris from this battle. People's urine will get darker as well, and it's important to drink a lot of fluids here to try and flush all this stuff out. But muscle soreness is a common side effect of this entire process, as well as being tired. You know, all the energy is being driven to try and get rid of this virus. Now, you might have shortness of breath with mild exercise. Now, it's not unusual to have an increase in heart and respiratory rates with a fever. That's pretty common. And, you know, you get tired much easier when that happens. And just walking up the stairs may leave you a little bit short of breath. That's all normal. These are all early signs and symptoms. And the odd part is that these are early signs and symptoms of influenza as well, or a regular cold. So it's difficult in COVID-19 to tell if those signs and symptoms, if you're experiencing these signs and symptoms, is this a cold, is it the flu, or is it COVID-19? And there really isn't, remember, there's no treatment for this. We don't have a vaccine for this. So if this is all you get and you start feeling better in a week, 10 days, 2 weeks, then great. It doesn't really matter what it was, except it's nice for epidemiological purposes to know if you were infected by COVID-19 and whether or not you have some immunity now, or whether you are shedding the virus and can transmit it to other people. Now, some people, very, very few, also have some nausea, vomiting, and diarrhea, and this would be an unusual symptom. But remember that because the esophagus is another tube that is connected up there to your oral airway and your nasal airway, the virus can actually infect the digestive system and start to crawl its way down, infecting cells along the way. And the virus has been found in the stool samples of some people that are infected. No one theorizes that it's possible to get an infection from a fecal-oral transmission, but there's no documented cases of that yet. So as cells become infected, your non-specific cellular defenses, we talked about fever, other phagocytes that can come in and try to attack the virus, and your immune system is going to get stimulated. Now, if these are going to work, they're going to be able to destroy the virus and you're going to recover. And for the most part, these are the signs and symptoms that most people see, and then they recover. They recover just fine. The problem comes in is if the virus continues to go down into the lungs, and that can be problematic indeed. Let's look at that. So as the infection reaches the alveoli and the inflammation increases, the patient may develop a pneumonia and later an acute respiratory distress system, or ARDS. And if that happens, it becomes harder and harder for them to breathe without the use of a ventilator. Okay, so let's take a look at what this looks like. So someone coughs or sneezes and they get infected by the virus. So we know what those early signs and symptoms are because it infects the initial upper airway. And then it can migrate as the infection gets worse and worse. It can migrate down into the lungs. Now it doesn't have to, but if it does get into the lungs, it's going to cause some problems. So let's look at what actually happens once it reaches the lungs. Now remember that your body defenses could stop this at any point in this progression. And if so, then you're going to recover. So let's take a look at what's going on in the alveoli. So inside the air sacs of the lungs, there are a number of different cells that are there. One of those cells is a type 1 pneumocyte, and these are responsible for gas exchange. In other words, when oxygen gets absorbed into the capillary beds around the alveoli, or when CO2 is moving out of the capillaries and out of the bloodstream into the alveoli, it happens through these cells. Type 2 pneumocytes produce something called surfactant. Now, surfactant is what it does. It decreases the surface tension within the alveoli, and it helps prevent them from collapsing. Without surfactant, they could collapse, and it would be hard to open them back up again. So this is important. It keeps them sort of slippery on the inside. So in this particular drawing, that sort of grayish, orangish color there indicates the surfactant. Now, the third type of cell that is inside each one of your air sacs is a macrophage. Now, these are very, very large white blood cells, and the reason they're there is that they're responsible for moving particles and microorganisms from the inside of the alveoli. And this helps with, helps control bacteria, it helps control viruses, and anything that gets in there, smoke, dust, okay, that these macrophages come in, they gobble it up, and they prevent it from getting some sort of lung infection or damaging the alveoli. Super important, and they're present in every single one of your alveoli, all throughout the lower airway. Now, here we see COVID-19, and it gets attached to the ACE2 receptors in the type 2 pneumocytes. And then it multiplies, and the virus escapes and starts to build up inside the alveoli. And then neutrophils, which are a smaller version, another small white blood cell, that are released by the bloodstream into circulation, and then the capillary beds surrounding the alveoli vasodilate, allowing these neutrophils to enter the alveoli itself. And so they're coming in there to help fight this thing. It's a normal inflammatory response when something is irritated. But the problem is that this is happening in your lungs and it's happening inside your alveoli. So that means that now there's a whole bunch of debris getting caught up in there. There are viruses that are being released in there. So it's getting harder for this person to breathe. It's getting a little bit leaky because the capillaries are leaking a little bit of plasma, and that plasma is leaking around the alveoli and into the alveoli a little bit. And then the neutrophils are coming in here, and they actually can make things worse. They release inflammatory and toxic substances. Now, the inflammatory stuff can make the inflammation worse. It can make the edema leaks worse. And they also release toxins that are designed to kill different things. But in this case, if there's an overwhelming number of neutrophils that come in, they're going to release toxins that actually start to destroy the inside of the alveoli even further. And so if this person's already having difficulty breathing and a little bit short of breath, it gets worse. This accumulation of debris can start to even show up on x-rays and MRIs. And you would know that it's happening because the person is having more and more difficulty breathing. Their respiratory rate goes up, their workload goes up. And if this continues, if the leaking continues, then the fluid that's building up on the outside of the alveoli starts to pressure it in and tries to collapse it. And the fluid that's now leaking into the alveoli sort of dilutes the surfactant and then makes it harder and harder for the alveoli to stay open. It likes to keep them collapsed. So these people are now having even more difficulty breathing. They're not getting enough oxygen in. They have to work really, really hard to inflate their lungs because it's not working very well because each little alveoli is being squished. And these are the folks that end up on ventilators. They end up with positive pressure being forced in there, so their alveoli open up and they're forcing more oxygen across that boundary into the capillary beds. And the question is this going to be effective or not? It may buy their immune systems enough time to develop antibodies and for them to recover. It may not as well. Now, what also is happening in addition to this is that some of these virus particles and all of these inflammatory mediators are now moving out of the alveoli into the bloodstream. So then you can have this infection going systemic. And remember, there are ACE2 receptors in many parts of your body. So these viral particles are now traveling around inside your bloodstream and can attach to different organs. In addition to that, the inflammation is getting worse, and so you have a systemic infection, you have systemic inflammation, and a systemic infection is called sepsis. And that can develop into septic shock, where so much vasodilation is happening all over your body that your blood pressure starts to fall. And as other organs become infected or become affected by the inflammation, you end up with multi-organ failure and death. Now, if you think about this for a little bit, you can see that anybody who has any type of lung condition or respiratory problem, they're going to be much more susceptible to this and more likely to end up on ventilators. Likewise, people that have circulatory system problems, diabetes, cancer, any severe underlying or chronic illness, they're not going to be able to handle any type of systemic infection that starts to happen. And that's why a lot of these people are more susceptible populations. The older people above 60, you get above 80, but there's more and more chronic diseases in our older populations. And that's why also some of the younger people with chronic diseases and problems are also dying or being put on ventilators. So what does this whole picture look like with respect to signs and symptoms? All right. So once someone gets infected, let's say call that day 0, one of the things that we've been doing is saying, hey, it takes a couple of days for symptoms to show up. And sometimes they don't show up at all. So if you have an asymptomatic patient, they're after 3 days, they're going to be shedding the virus. And if they cough and somebody else is nearby, they can infect other people. Now, many of the asymptomatic people, while they are shedding the virus and they can infect others, they only about 10% of them actually go on to infect other people because they actually have to cough. They have to touch their mouths and transmit the virus in droplets in other places. So it's much less. Not a lot of people are getting infected by asymptomatic people. Now, most of the people are getting infected by people who are actually symptomatic. And so while you're asymptomatic for a couple of days before you get symptomatic, it's when you really start getting that cough that you start throwing these virus particles out and infecting other people. And that typically happens around day 5, can go up, and you can be symptomatic for, much longer than that. And then if your body's defenses are working, then you start to heal, you start to feel better after a couple of weeks, and eventually the hope is that you recover. But you're still shedding the virus during that time period. And the potential is that, yes, you're going to infect more people while you're symptomatic and coughing, but even after your symptoms start to get better, you can still infect others. So you need to wait another 14 days after that, after you feel cured, to make sure that you're not likely to infect other people. So that's, we're talking 5-6 weeks of, individual quarantine once you end up knowing that you're sick. And you're going to start feeling better about halfway through that, ideally. Unless, of course, you feel worse and it starts to go into your lungs, and then you need a hospital. So let's take a look at signs and symptoms. I've already spent a bunch of time talking about asymptomatic patients, and to realize that, yes, if you're asymptomatic and you have COVID-19, you can infect other people, but the infection rate is not nearly as high as if you're symptomatic. So the mild signs and symptoms we've already discussed, and they're mostly attributed to an infection of the tissue of the oral and nasal airways, and then the back of the throat. So that upper airway is what's producing those mild signs and symptoms. The more severe signs and symptoms happen when the virus actually gets into the lungs. So some of those are as you get short of breath at rest and you have to work much harder to breathe. That should be concerning, and you really need to be in a hospital at that point for monitoring, because at any point you might need to be put on a respirator should one be available. You're going to be really tired. You're going to be weak. There's a lot of fatigue in here. Your heart and respiratory rates are going to go up, and you're still going to have that fever, and it may or may not get worse. If you start to develop a productive cough, this is a viral pneumonia. In other words, it's not bacterial, it's viral, okay? It's a result of that fluid leaking into your alveoli. And so you end up coughing up, and you're very, very contagious at this point. Some people that recover from this will actually develop a secondary bacterial infection that could lead to a bacterial pneumonia, which is just adding, more problems on top of something where you ideally were getting a little bit better. And then if your blood pressure starts to drop, you're feeling even worse. Most of these are people on ventilators by this point. If there are any available, then they have multi-system organ failure and die. And that's about only 20% of the people that are on ventilators actually live, and they end up with some severe scarring inside their lungs. So if that's what happens, what's going on? Well, the problem right now is our healthcare system is really overwhelmed, or it's going to become overwhelmed in different areas. There's not enough ventilators. There's not enough technicians to operate at ventilators. There's not enough medication to keep people on the ventilators. There is not enough protection for the healthcare workers. So there's not enough beds in the hospitals and the intensive care units. So if we do not engage in some sort of protective measures, our healthcare system is going to continue to be overwhelmed. And the people we depend on most for protection are going to get sick as well. So this becomes a community health issue. We've got to start taking protective measures to drop that curve down to meet our current health system capacity. At the same time, we're trying to build the capacity of that system a little bit, getting more beds, getting more ventilators, getting more equipment, getting more testing. All that stuff is super important, but that's what's going on in many places around the world right now. So how do we decrease the spread of COVID-19? I think most of us are aware of this right now. We may not be aware of why it's so important, but the reason it's so important is because our system, our healthcare system, is being completely overwhelmed. So what we can do is avoid non-essential travel. This is important so that we don't have somebody who is asymptomatic moving into an area that doesn't have any cases or has very few cases and then spreading it. So we need to avoid non-essential travel until we can test people and make dang sure that they're not carrying the virus or shedding it. We need to have ongoing and extensive community testing and then contact tracing. In other words, we need to test people whether or not they feel sick or not. We need to test everybody, and we need to keep doing it so we can find out where the virus is and know where we need to have some interventions to be able to keep the spread down. And then when we find somebody who has the virus, we need to figure out who they've been in contact with for the last couple of weeks, because that'll lead us into more people that we need to test and check and see where the virus is spreading. So when we're in public, and I think you all know this by this point, is that some of the few things that we can do to slow the spread of this virus is physical distancing. A lot of the droplets that are coming out from coughing and sneezing don't travel very far, 6 feet, somewhere around in there. Want to be more careful, go out to 10 feet. 6 feet seems to be the best recommendation at this point. We want to wash our hands on a regular basis so that we can make sure that when we touch our face that we don't pick up the virus from some sort of public surface, transmit it, and self-inoculate ourselves with the virus by touching our mouth or our nose. And we can enhance the protection of physical distancing with a mask or face covering. Now, we have to realize that we're low on the N95s, the masks that the healthcare providers are wearing. We don't have very many of those, so any type of face covering will help reduce it, but we can't all be wearing N95s right now, and they're not absolutely necessary at this point. They are necessary for the healthcare workers. So with physical distancing, you don't need an N95, but you really ought to have a face covering, surgical mask. There are a bunch of other masks available out there that'll do the job. We need to continue to regularly disinfect community surfaces to interrupt the contact transmission. And we need to not touch our mouth, nose, or eyes when we haven't washed our hands. We need to only touch our face. It's okay to touch our face with clean hands, not okay if they aren't clean. So when we're at home, we still are disinfecting community surfaces, and we are still maintaining our personal hygiene and hand washing, just in case something gets inside our homes. And then ideally, we're going to develop a vaccine. Now, vaccines typically take about 10 years to develop and test. We don't have 10 years, or we hope. We hope we can get a vaccine out there much sooner. Now, MERS and SARS are also coronaviruses, and they died out. But while they were in the process of dying out, there was some funding for vaccines, and they're all coronaviruses, so some of that vaccine development has helped jumpstart the development of vaccines for COVID-19. So if we're really lucky, and we're working really hard, and still got to have a lot of luck, we'll have a vaccine in a year to a year and a half. And once we get that vaccine out and dispersed amongst the population, we're going to see this drop down and drop out, and then we'll be able to start resuming a more normal lifestyle, if you will. With respect to immunity, we know that people are coming out who recover from the virus. The majority of them do have a level of antibodies. Some of the antibody levels are very low. We think that has to do with the initial viral load. Some are quite high, but we don't know how long they're going to last. There are also some individuals who have tested positive for COVID-19 when they recover don't show any antibodies. So there's a few rare individuals out there wandering around that don't get antibodies and don't have immunity and could potentially get the virus again. So this raises a couple of questions that are really, really important. Can we maintain a stable economy and take protective measures at the same time? And the answer is probably not. We're seeing that happen right now as we get these stay home, stay healthy orders from our governors or city officials and saying, hey, we need to knock down this the spread of this virus. And people can't work. And if they can't work, they can't make any money. If they can't make any money, they can't buy food, they can't pay their rent, they can't pay their bills. So the economy is going to get infected if we take protective measures. And we're seeing that happen. Well, the converse question is, well, what happens if we don't take any protective measures? Will the economy remain stable? And the answer is no, not if our healthcare systems are being overwhelmed. People are going to be scared. They're not going to show up for work. They can't work if they're sick. So the economy is going to take a hit either way. The question is, can we save people and knock things down? And that's why we're taking the protective measures right now. We're really dealing with, this very, very fine balance between community health and a stable economy. And that means that we have to know where the virus is. We have to be able to balance the distancing measures that we're using community to community, which is why the ongoing testing, community testing and contact tracing is so important and why a vaccine is so important. So I hope this video has helped you understand COVID a little bit better and to understand why the government's being involved and doing what we're doing in order to knock down the number of cases, to reduce the number of cases. So thanks, and if you haven't seen part 1, go for it. Take care. Bye-bye.